Welcome everyone to MUSIG's first event for 2018. My name's Sophia, I'm one of the co-chairs of MUSIG for this year, and this is Ed, the other co-chair. So for those of you who don't know, or all the first years who are here, are there a lot of first years here? Do you want to chuck your hand up if you're a first year? Okay, so there are a lot of first years. Okay, so we weren't at your O week. We didn't have a stall, so you might not know much about us. So MUSIG is Monash Uni's surgical interest group. So we're a group, we're all students, and our aim is just to promote surgery as a potential career in medicine, and also get you guys to have a look at maybe some aspects of surgery that you don't think about straight off the bat. So issues that arise in surgery, research that you can undertake to become a surgeon, all that kind of stuff. We run lots of different events throughout the year, and most of them are hands-on workshops, which is everyone's favourite kind of stuff. So we do things like practice suturing and other techniques that you need to learn to be a surgeon. So keep an eye out. Like our Facebook page if you haven't already, because we post all of our events on the Facebook page first. And that's important for ticketing as well, because as you can imagine, there's a lot of you here and there's a lot of people who come to our workshops. So yeah, thanks again for coming to our event tonight. We're still waiting on our first speaker to arrive, so feel free to just chill and mingle.
But we're just going to have a quick word from our sponsor for this event tonight, MIPS. Do you want to
Yes,
a couple of things, Margaret?
thank you. Oh, do you want to put something
yes.
up? Yeah. Hi guys, I'm Margaret from MIPS. Normally you would see my colleague here, Tamar, but he's over at, there's another info session on tonight about John Flynn, and that's with wildfire. So if you, can I just say about John Flynn? If you're interested in John Flynn, it is a really, really good program to get involved in. So look it up. I won't go on. Sorry. So is surgical. So, most of you are first years. So do you even know who we are and what we do? Because the orientation day, all you did was take a bag, take a bottle. Yeah, cool. All right, so we're one of the indemnity companies. So basically what we do is we cover you for complaints and if you're sued by patients. So there were 4 of us there on the day. When you are a student, you can join all of us. And because it's free, why not? You get all of our free stuff. And then when you start having to pay, at least you've made an informed decision then about which one you'll stay with for the rest of your medical career. Because historically, when you do stay with one, you usually choose one, then you pay with it. You don't really change, unlike health insurance and car insurance. We're a claims-made insurance company. So what that means is that the longer that you have insurance with a defence organisation, the better for you, because what happens is we cover you for retroactive cover, and what that means is that something may occur in the past that's happened. It may potentially turn into a claim in the future. So there's things that might happen that we can't even predict that will happen. So the longer that you are with one company, the better it is for you. So that's why we ask you to join as a student, and that's why we offer it for free. So a lot of people think, well, I'm a student, I don't even need it, I'm just studying. But that's why we ask you to join, so that you've got that cover right back to when you started. So anyway, I'll go on with my presentation. So that's just the legal jargon to say I'm giving you general advice. So, as I said, our purpose is to protect, support and safeguard your professional character and interests. The main membership benefit is professional indemnity insurance cover, and what we do is we cover you for the acts, errors and omissions that may occur when you are providing healthcare. We're a not-for-profit mutual, and what that means is that we don't have any shareholders. So when we do make a profit, and we are a very profitable company, we're the most financially stable one, we give our profits back to you guys. So essentially there is a fee attached to your membership, so it's probably $10 or something, but we're paying it from our profits on your behalf. Okay? We've got over 50,000 members now, and about 15,000 of those are students. Now, I will say, you can see down there, we're running a competition, and it is to win a voucher, one of 2 vouchers for $500, but you need this boarding pass to enter the competition. There's a link and a code that you have to put in, and then there's 3 multiple choice questions in the competition. So on this page, there was one of the answers. That's all I'm going to say. Maybe look at the second one. Just a bit of a hint. So for you guys, it's free, as I've said. It covers you for your clinical activities and studies, elective placements, and also John Flynn, if you go to do that. And if you do an overseas elective placement, we do have free travel insurance as well. One of our competitors doesn't anymore, so you might want to use us. And we also cover you for Good Samaritan Acts. There is more. We have additional support. No sublimit, so what that means is that we have no limit. We cover you for $20 million. The government we are governed by the government to cover you for $20 million. But what other companies do is they put caps on what they cover you for. So say, for example, you have to go to court and the lawyer's fees go up to $50,000. One of the other companies will put possibly have a cap on what they cover you for that. So we don't do that, we just have $20 million. We have MIPS protections, and MIPS protections covers you for non-indemnity work-related matters. And something that comes to mind for a student is that they were accused of plagiarism by the university, and we helped support them to disprove that. So that's why you do need us as a student. We do have risk education, online modules and sessions that you can attend, webinars as well now. And the best thing about with us is that we've got the 24/7 clinico-legal support, and our phone is always manned by a doctor. So when you call us, they know clinically what you're talking about and also legally as well, and that's a great thing to have. There's still more. The travel insurance, as I told you about, and we've also got a cover for communicable diseases. That's one of those words I can't say. As I said, it's free. When you do eventually graduate, there's no obligation to stay with us. We will re-invite you to join us as a new grad. This year we're waiving fees up until postgrad year 3, and as I said before, because of the profits that we make, that's how we're able to do that. So here's a case study which I thought you might be interested in. During a clinical round, a registrar supervised the student to insert a cannula. Despite the student's familiarity with the procedure, there was a problem. There were 2 failed attempts, and afterwards the registrar inserted the cannula successfully. Unfortunately, the patient developed a large haematoma at one of the sites and it became infected. And then the patient complained to the hospital. The hospital wasn't happy about it. The patient was annoyed, and the patient was annoyed that the hospital had let a student insert the cannula, and both the registrar and the student were contacted by the hospital's legal team. The university, unfortunately, were not very supportive of the student, and they left him to himself to respond to the patient and the hospital. And just imagine doing that now, how daunting that would be. So because they're a MIPS member, they contacted us, and we helped the student draft a letter of apology to the patient and a statement for the patient and the hospital, and the university approved all of us. And then no further action was taken. So that's a good case study to have a think of if you think that you don't need medical indemnity. We do cover, as this is a surgical careers night, you know, obviously you guys are possibly thinking about doing surgery, so we do cover you through your whole career, from student through to whatever you decide to do later on. There are different levels of cover, and as you go on, you'll hear more about those if you're interested in staying with us. We're on social media, so Facebook and Instagram. Our Instagram is a bit weird. It's MIPS_Insta. So if you want to get your phones out and have a look, you can start following us. Do you follow on Instagram? Yes? I don't know. I'm on it, but I don't know. And there's the competition. So if anyone wants a boarding pass, what I might do is pass this around. I'll pass this around. If you could just fill in the details there, write your email really clearly for me, and then what I'll do is, however many have put their name down on here, I'll leave them with the committee members, and you can collect one from them at the end. Does that sound okay? Make sense? Yeah? Okay, good. And I think that's it from me. Oh, this is a good thing I heard from a doctor say one day. You can't make a reputation in a day, but you can ruin one. So when you are out there in the field, you guys would have, studied for so many years trying to build up a good reputation and having a good name for yourselves. Just make sure when you do choose your indemnity company that you do choose one that also has a good reputation. All right? That's it from me, unless you've got any questions. Thank you.
So our first speaker tonight is Professor Julian Smith, and he's the head of Monash University's Department of Surgery. He's also the head of the Department of Cardiothoracic Surgery at Monash Health, and he's the deputy head of the School of Clinical Sciences at Monash Health. He graduated medicine in 1981 and has obtained a fellowship of the Royal Australian College of Surgeons in General Surgery and Cardiothoracic Surgery. He's also a fellow of the American College of Surgeons and is on the council of the Australian and New Zealand chapter. He's recently a member of the first cohort of graduates to obtain a Master of Surgical Education from Uni of Melbourne and was the first Australian to receive a fellowship of the Faculty of Surgical Trainers of the Royal College of Surgeons in Edinburgh. Professor Smith has in excess of 300 publications and $7 million in grants, making him one of Australia's leading academic surgeons. Can we have a round of applause for Professor Smith?
So thank you very much for that kind introduction, and it gives me great pleasure to present an introduction to a career in surgery. I recognise that not all of you are going to do surgery, but it is certainly something to give some consideration to as you go through the medical school journey and beyond. So what I'm going to do is talk to you a little bit about my branch of surgery, because I think it's important that you guys have an idea of what surgeons do. I'm sure you've got a perception and you've seen stuff in a variety of contexts, but I thought I'd give you a little bit of an explanation about what surgeons do. I'll give you my own story in brief, and I'll try and give you some advice about how you should make good use of your time as a medical student, especially if you are considering a career in surgery, and a few comments about tips and tactics as you go through. So I'm sure most of you know what surgery is. It is the art or practice of treating injuries, deformities and other disorders by manual operation or instrumental appliances. A very simple definition, though, is that we are actually all physicians who operate. We are still doctors. We're not plumbers, we're not technicians, we are doctors, physicians who happen to treat patients by operating. Some people don't like me saying that, but fundamentally that is the truth. I consider myself a cardiologist who operates. Now, the College of Surgeons believes that technical surgery isn't just the be-all and end-all. There are a variety of other characteristics that a good surgeon should have. It is a truism. We should be a medical expert. We should know about what we're dealing with. We should have good judgment and clinical decision-making, and we should have the technical skills to perform the surgery. And so it is an important prerequisite that you be able to cut and sew and use your hands and have reasonable dexterity. But there are other characteristics. We need a high level of professionalism. We need to advocate strongly for the health of our patients, but also for our own health. And you as medical students should do the same. Be advocating for your own health as well as those around you. Good communication is essential because we are in significant teams and there are many people involved in the surgical endeavour. We collaborate amongst ourselves and with others. Surgeons need to be strong leaders and competent managers. And not every surgeon will be an academic surgeon, but every surgeon should have a capability of scholarship and teaching in relation to those around them. So my first message is surgery is not just operating. Now, I thought I'd use cardiothoracic surgery as an exemplar concerning a typical surgical life. Now, cardiothoracic surgery involves the surgery of the heart and lungs, the chest wall, and to a lesser extent now the esophagus, because esophageal surgery is often done by upper GI surgeons. But we have a variety of important activities. We do look after patients, but we also teach people like you, young trainees who aspire to be cardiothoracic surgeons or other surgical specialties. We undertake basic science and clinical research. We all have to administer. We administer our own practices, and we may lead and administer surgical departments or other groups. And no matter what we do in surgery, we have a leadership role. And we lead a significant team. Surgeons do not operate in isolation, and cardiothoracic surgery is has one of the largest teams involved in patient care. Cardiothoracic surgery, as I said, involves surgery of the heart and lungs. Thank you. We require a lot of technology, such as the heart-lung machine, multiple monitoring devices. Some of the surgery is done with a variety of endoscopic or robotic techniques, and therefore it is very labour and technology heavy. But it is a very rewarding and stimulating branch of surgery. Now, the common procedures done by cardiothoracic surgeons are coronary artery bypass surgery, which you can see in the top left box, valve replacement or repair surgery, surgery for lung cancer, which is often done through video-assisted techniques or minimally invasive approaches in the middle bottom box, and we do a variety of lung operations through a larger thoracotomy. But there is a wide spectrum of conditions that are managed by cardiothoracic surgeons. We also operate on the thoracic aorta. We sometimes have patients with tumours in the heart, which is the top right. We put in pacemakers and defibrillators for patients with rhythm disturbances. We do heart and lung transplantation, which is the middle one and the bottom, and also a wide range of operations in childhood, which is, as you can imagine, a pretty super specialised area. There are many emerging technologies in surgery, and one of the most common ones is the minimally invasive or keyhole approach. And that has been applied in cardiac and lung surgery. Also the use of robotic assistance and artificial heart technology, with miniature pumps used to support the circulation. We collaborate closely with our cardiological colleagues because they are doing some of their procedures catheter-based and using percutaneous techniques. And we may assist or actually do the procedures in association with the cardiologists. And we insert heart valves through the groin, we clip mitral valves and do a variety of other procedures in a very minimally invasive way. We have operated on a few famous patients over the years, and cardiac disease is pretty ubiquitous in our community, and there is plenty of work to do. At Monash, we have a pretty proud record in cardiothoracic surgery, both in research and in clinical practice. And there are many cardiothoracic operations done at most of the large Monash teaching hospitals. So there are a number of prerequisites to pursue a career in surgery. One does need to have some degree of technical skill that is inherent, but it can be learnt through appropriate training. One needs to have a love of operating. I don't think a surgical career is terribly rewarding for a doctor who doesn't enjoy operating. It is a bit of a marathon. There is a fairly long training program, but in the end, it is very rewarding for the patients and for the surgeon. Surgery is organised through the College of Surgeons in Australia and New Zealand, and there is a Society of Cardiothoracic Surgeons, which has a lot to do with the specialty locally. So that's just an exemplar of a surgical career. Now, how do you get there? You guys are sitting as young, enthusiastic medical students thinking about career opportunities, and it might seem a pretty scrubby, windy, obstructive sort of pathway. But it's not necessarily so, but there are a number of hurdles that one has to overcome to get to the desired destination. But the journey is actually quite rewarding as well. It's not just the destination, but it is also the journey. So I can give you a brief synopsis of my own journey. I graduated from that other large university in this city, and I worked at one of their large teaching hospitals as a medical student and then as a junior doctor. I did some general surgery training because at that time it was felt that general surgery was an important prerequisite for any surgical specialty, that you had to grasp skills of operating on a variety of conditions, not just in the abdomen, but a lot of surgical trainees at that time did a lot of general surgery beforehand. These days, it's not considered as important, and coming into surgical training, one tends to get straight into the area of interest rather than doing a lot of general surgery. But at the time, as a junior doctor, I got involved in projects and publications fairly early on as a means of extending an interest that I had in research, but also as a method of enhancing one's CV and also one's candidature for surgical training. And that is an unfortunate fact of life now, that it's pretty competitive to get into surgical training, and one has to be mindful of methods of enhancing one's candidature. I did general surgery and then a bit of cardiothoracic at the Royal Melbourne, but I had a particular interest in heart and lung transplantation. And so soon after the unit was set up at the Alfred, I moved there to pursue my interest in that subspecialty of cardiothoracic surgery. I completed the cardiothoracic training at the Alfred, also did a little time in paediatrics at the Children's, and continued with projects and publications. I must add that I did a Master's in surgery while I was at the Royal Melbourne, some dedicated research and a higher degree. It's considered a nice thing to do, but not necessarily obligatory these days, is to spend a little time internationally to just enhance one's experience within a surgical specialty, to see another surgical and medical system, and just to broaden one's surgical horizons. And I was fortunate enough to do a fellowship at Stanford University under Norman Shumway, who was one of the fathers of American transplant surgery. And it is there that I extended my interest and experience in heart and lung transplantation, but also in minimally invasive cardiac surgery. And it's fair to say that the overseas experience establishes lifelong collaborations, networks and friendships. And it is great for Australian surgery to have this interchange, but I believe that the international surgical institutions gain a lot of benefit from us going there, because we are very well trained in Australia and they enjoy our interaction over there. So I spent 1.5 years at Stanford, and then I went to the UK for a year. And Papworth Hospital is a dedicated chest facility just out of Cambridge, and I did more heart and lung transplantation as well as general cardiac and thoracic surgery. There I extended my interest in mechanical support of the circulation. So going to internationally, you can develop interests within the surgical specialty you have chosen. After that, I returned to the Alfred Hospital as a cardiothoracic surgeon, particularly involved in the heart and lung transplant service under the late Professor Donald Esmore. And that was where I continued my academic activities as a senior lecturer, and then the chair in surgery out here became vacant, and made application and was successful, and so I moved from the Alfred to Monash Medical Centre. A few years ago I went back to university, that terrible university over the other side of town, and completed a master's degree in surgical education, because I was interested in surgical research and I'd done a master's in surgical research, and then I was particularly interested to gain extra qualification and knowledge in surgical education. That was done as a part-time endeavour. As was mentioned earlier, I got involved in our society as a counsellor and then as president, and also in the College of Surgeons, because I feel that it's important to put back into the surgical community, and this was a great vehicle for doing such, and I was able to get involved in a variety of activities for the benefit of surgery at large. And I'm particularly involved at the moment in the Operating with Respect endeavour. You're probably aware that surgery has come under a bit of attack because of behavioural issues within surgery, and the College of Surgeons is doing their level best to address this, and one of the methods is the Operating with Respect courses that are for trainees as well as practising surgeons. My international connections have been continuing through the American College. Having spent time in the United States, I developed quite a feeling and admiration for what American surgery involves and offers, and so I've been involved in the local chapter of the American College of Surgeons. It's interesting, medical students can join the American College of Surgeons as associate members and gain access to many of their educational offerings. Along the way, I've had a particular interest in academic surgery because it is a very diverse and stimulating endeavour. But as I said, very few surgeons take on a career in academic surgery, but every surgeon should be competent in academia. That is in teaching and also have a feel of interpreting the surgical literature. A career in academic surgery, or academic medicine for that matter, does advance one's surgical career. It provides definite diversity from just looking after patients. It gives one an opportunity to further the art, science and craft of surgery, but in an obligatory fashion is lifelong learning and critical thinking. But as I said, every surgeon should have an academic capability, but maybe not a career academic surgeon. So cardiothoracic surgery offered plenty of opportunity there, and my interests were in mechanical support of the circulation as well as minimally invasive endeavours. But we've also worked on complications of using the heart-lung machine, particularly related to renal dysfunction, and also the use of blood and blood products in our specialty. And so surgery is a very fertile area for research. And then there is, of course, surgical education, because we just can't sit still. We have to educate you guys as well as trainees in the best possible way. And things like simulation has come to the fore in recent times to be an important adjunct in teaching within surgery. Now, just a few other comments about surgical careers. People think it is a male-dominated endeavour, which could not be further from the truth. Over half paediatric surgeons are women at the moment, and more trainees are female. There are challenges though, but a career in surgery can be combined with family life. The College of Surgeons is trying to embrace part-time training. It is challenging, but there are some examples of successful part-time training, especially for women, and there are opportunities in all surgical specialties. And women can make it to the top in clinical surgery and in academic surgery. My colleague Wendy Brown at the Alfred is such an example. She's Professor and Head of Department at the Alfred. Silvana Marasco is a cardiothoracic surgeon at the Alfred, who's just been appointed a Professor at Monash University. And so there are examples of women making it to the top and having very successful surgical careers. And it is something that I would encourage everyone to consider. Now, as a Monash medical student who might have an interest in surgery, how can you augment that interest or crystallise it or put it to bed? You may not end up wanting to do surgery. Now, the Year 5 rotations are going to change, and some of you in the room will probably be functioning this way. Others might be slipping into the new MD course where things are a little bit different. But anyway, with the current Year 5 rotations, there is a variety of ways in which you can spend a little bit more time around surgery but still complete your requirements. There will be you'll do a surgical core in any specialty. Your medical rotation may be in an area that has parallels to surgery, such as neurology or cardiology or gastro, where a number of the patients will be treated surgically. There are many surgical issues within the aged care domain because our population is ageing and more of our patients are elderly. The emergency rotation is an essential way of getting exposed to trauma and to acute surgery, where patients are coming with conditions requiring time-critical surgical intervention. We do have the specialty rotation, which involves time in the anatomy department as well as in a surgical department. And that it also offers an opportunity for some research. Then you've got the elective rotation, so you can take your pick and do any surgery you like. And if you're really keen, you can slide into a bit of surgery into your vacation tagged onto one of these other rotations. So if you're really keen, you can turn Year 5 into a pretty good segue into surgery. For those going through the new MD course, we will be offering surgical research opportunities as a part of the final year research component, but that's work in progress at the moment. But you may wish to avail yourself of that opportunity if it arises. So my message is that as you go through Monash Medical School, you can tailor some of your activities towards a career in surgery. And I know some students in the past have done that very successfully. The College of Surgeons, as I said, is responsible for surgical education and training, and their website has quite a lot of useful information. Obviously, a number of college leaders are affiliated with Monash, and there have been some articles in the ANZ Journal of Surgery about surgical careers and issues in surgical training, if you're particularly interested. So, just a few closing tips. You need to ask questions of those of us in the surgical community, such as interns, junior doctors, surgical trainees, junior surgeons and senior surgeons about what's involved in the surgical career. And you probably need to get exposed to as much as you can. And along the way, you may establish a relationship with a mentor within a surgical discipline that you might be interested in, or it could be someone who's in a surgical discipline that you may not have interest in, but is a very nurturing and encouraging mentor who can give you advice about how to proceed. Now, as a medical student, you might like to consider a BMed science year to immerse yourself in research with a surgical flavour. And most of the surgical departments affiliated with Monash University have a capability to provide a good year for a BMed science. And we have a handful of students in our department each year in a variety of surgical specialties who go ahead and do a BMed science. And that gives you a flavour of research. Usually the students get 1 or 2 publications. They do their minor honours thesis and can get quite a lot of mileage out of it. And it also helps enhance their candidature down the line. But it also gives you that exposure, and it might crystallise your interest, or it could dampen it down and you might choose something else. But anyhow, a BMed science year is time well spent at your stage, irrespective of where you end up in the future. I've already mentioned making the Year 5 rotations work for you in terms of exposure. Obviously get involved in surgical activities as best you can. Optimise your candidature for surgical education and training, but also have a good time because surgery can be a lot of fun. So our mantra, certainly in the academic world, is that we as surgeons are only as good as the people we train. And we try to leave a legacy of outstanding young surgeons who are actually better surgeons than us, because that is the way that the best possible care is given to our patients. And so with that, I might conclude. Be happy to take any questions, but I do recommend a career pathway in surgery, and Monash and its affiliated hospitals are a great place to start. Thank you very much.
Do you mind answering a few questions if we ask the crowd?
Yeah.
So, while Professor Julian Smith is still here, did anyone have any questions? It's a good time to ask him.
It is, look, a career in surgery is challenging. There's no doubt about that. It is time consuming. It can be physically challenging and it can be mentally challenging. And people's circumstances are extraordinarily variable. But it's important to realise that it's a solid commitment. And one's life has family commitments, there are work commitments, there's also your own personal commitment. And as I talked about health advocacy, is looking after your own health, those around you, as well as your patients. But it's fair to say it does challenge family relationships. There are many issues that surgical trainees and surgeons face with respect to family relationships. But it is manageable, and there are many, many successful surgeons, but there are a few who've had their ups and downs. So it's like any endeavour in life. But I think you have to realise that it is a significant commitment. I don't think you want to go. I don't think you go to medical school half-hearted. You really, medical school is a significant commitment, and being a surgeon is likewise. And training in surgery is a part of getting there. And I think you can't do it if your commitment's not quite 100+%. And also, to a large extent, the commitment of your family to support you going through. I think it would be very challenging if you didn't have committed supports, whether it's a spouse, parents, those nearest and dearest. So the answer is that there is definite impact.
Hi, I was just wondering what RAPS's current stance going forward is on rural or regional specialist training programs, like specifically, obviously you've got the metro ones you get sent out.
Yeah.
Are they looking at having any dominantly rural or regional ones?
Yes is the answer.
Are they putting this now, or are they still?
They're work in progress. They're work in progress. I think an example in Victoria is in the southwest, based at Geelong, sort of out of Barwon Health, but with a significant focus in the southwest. There is also, I think, in regional New South Wales and Queensland, some networks where there is a focus on rural surgery. Rural surgery is almost a specialty in itself because the facilities and resources are not as strong as in the metropolitan zones, and the surgical practice is often broader, that within a given surgical specialty, the surgeons are doing a very broad range of surgery. And so the training needs to be a little different. And so a general surgeon might have some skills in fundamental neurosurgery or thoracic surgery, which wouldn't necessarily be required in a large metropolitan hospital. And the specialists in other surgical disciplines might do a wider range of procedures than they'd ordinarily do if they were in a metropolitan hospital. But the college is very cognisant of rural surgery, and there are some dedicated groups within the college addressing that.
In terms of timeline from when you finished medical school on average, or in your case, how long did it take until you became a consultant?
too bloody long. 14 years. And you add, if you add 6 years of Melbourne Medical School, it's a long time. It's probably a little bit shorter now because I did 3 or 4 years of general surgery as well. So that can put you off. And that was, I was talking about commitment. However, you are being paid for your time after medical school, which helps, but you work long hours, but you're paid pretty well. You can do it a little shorter than that. I mean, not everybody goes overseas, and look, it's probably closer to 10 years after graduation, I would say. But these are issues that you have to consider.
Is that in specifically cardiothoracics, or is that in average time among other surgical specialties?
It's probably amongst other surgical specialties. One surgical specialty that is particularly challenging is ophthalmology, where a lot of the ophthalmology trainees have spent time doing PhDs and a variety of other surgery before they got into ophthalmology. And that can be a bit of a long haul. But I wouldn't worry too much about spending a long time doing it, because you gather the surgical experience, and a few years early after graduation, training or getting experience, at the end of the day, once you get into practice and have a career, is not a major issue. And it's fun. You know, you've got other exposures. You can travel, go interstate, overseas, whatever. So it's not all doom and gloom, but it is time consuming and there is a commitment.
What motivated you to take up surgery?
Me? Well, I just liked anatomy. I was reasonably keen on operating. I was pretty, interested in fiddling around, carpentry and that sort of thing when I was a kid. And I came from a family of doctors, so it did sort of kindle the interest. And, there weren't as many options, actually, when I graduated. And seemed pretty good at the time. Would I do it again? Definitely.
Next question. What sparked your interest in academic surgery in particular?
Academic surgery, I just like the diversity. Enjoy teaching and research, and just provides just something extra to help the patients and sort of put back into surgery.
Are there any other questions? If not, then can we give a big round of applause to Dr. Julian Smith? So guys, if we could just have a little bit of quiet. So our next speaker is Dr. Joanna Lennihan. She actually graduated from Melbourne Uni, but despite this, she's now a highly successful orthopaedic surgeon at Eastern Health. She gained her fellowship in 2011, and she's kindly given up her time to speak to us about her experiences.
Thank you. Thank you. If I just stand here, that's okay. Thank you. I feel a bit underprepared. I just took a few notes on my pad to talk about. So, hopefully it's not too self-indulgent. It's more my personal story of how I came to do surgery and orthopaedic surgery, and work-life balance. And at the moment, for me, that the balance is kind of tipping away from work at this point in time. But this is my excuse if it gets a bit rambly, it's because baby brain is a real deal. Because look, I did struggle quite a bit with making my decision to do surgery, I knew that I really loved surgery and I really loved orthopaedics, and that was what I wanted to do. But for two reasons I really struggled. One was self-doubt, and part of that is just my natural personality, and part of that's also feeling like I was not the mould at all. I'd be the least likely person who started med school that you would think would end up doing surgery, and in particular orthopaedic surgery. And the other thing was, I was really concerned that it would mean sacrificing meeting a partner and having a family. And in the end, I decided that I could choose to do a career that I was less happy with, and still not meet the right person and still not have a family. And I thought, look, that would be the worst case scenario. At least if I don't meet the right person, it doesn't work out, I can't have children, at least I'll be doing the career that I want to do, basically. So I do orthopaedic surgery. I work at 2 public hospitals. I don't do any private practice at this stage, and that's been a decision to help with my work-life balance, because private practice kind of notches up the amount of stress, basically, because you have to run your business, you've got overheads coming in, you just don't have the same kind of flexibility as you do working through the public system. So currently I'm working 2 days a week, so that's 4 half-day sessions, which is the great thing with surgery. You have half-day lists, half-day clinics, so I do 2 clinics, 2 lists every week, and I spread that over 4 days. So, and I've got a 2.5-year-old daughter that I also look after. So I do, I believe in outsourcing. I get a cleaner to do cleaning. I've got a nanny for 1 day a week and also to help with drop-off and pickups. And Eleanor, my daughter, goes to childcare this year 3 days a week. So that's how I kind of achieve that balance. And training was really difficult and was full on, and I vowed at that stage that once I finished my training I would never work full time again, and I haven't. And it's everyone wants different things. Some people want an absolutely full on career. For me, I was like living the dream to work part time, have some enjoyment outside of work as well. But look, I hope this becomes a bit autobiographical, a little bit kind of, like I say, a bit indulgent, but I think I should probably start by saying that my father was a surgeon, and that's probably been, it's influenced me a lot, obviously, and I don't think I ever would have ended up doing surgery if I didn't have that little bit of confidence that, not that it's in the genes, but someone in my family, I honestly don't think I would have had that last little bit of courage to think I could do it if I hadn't known that, that my father had done it. But my dad was very, very old school, very traditional. He was actually a urologist, and he never came home from work before 8 o'clock. And Saturdays would be ward rounds in the morning for him, and then at home kind of just dictating and doing work. And so Sundays were family days, and he took 2 weeks we had 2 weeks of summer holidays every year that he would have off. But that was pretty much it. So certainly growing up as his child, I kind of thought of medicine and surgery as a bit boring and a bit full on and a bit too much work. So what changed, I guess, getting towards the end of high school, there were, again, two things. I found that I was pretty good academically and that I actually liked the challenge and liked learning things, and I got probably a bit ambitious. And my father also got sick with stomach cancer, and so in the last couple of my high school years, he spent a lot of time in hospital. He had several operations, he had chemo, and I guess I then became quite familiar with it and with the medical world, and thought, it's probably going to sound a bit arrogant, I could see how it could be done better. I could see what I could offer, and I could see, you know, for going through it from the kind of patient side, how, you know, it was a full-on experience, and even just a nurse saying something kind or noticing something small, it just made such a big difference at a time that was really hard. And I think a lot more of the medical surgeons that were involved in his care was a lot more clinical, and I thought there could have been a little bit more softness, which is probably what, I just thought I could combine those things a little bit more. So, so actually I ended up getting onto medical school, and was a couple of months into it that my father did die, and we had a very awkward conversation where he wanted to pass on some of his advice to me for the coming years, and he said, you know, and everything that he'd achieved through surgery and all the successes that he'd had and the positions of, you know, highly respected positions and whatever that he'd done, and head of unit and that type of thing, said nothing had fulfilled him or satisfied him as much as having a family. And you know, that was nice to hear, because we didn't see a lot of him at all growing up. My mum did all of the child raising. There was 4 of us. But I guess it's something that's kind of stuck with me. I think he actually said that because he was kind of angling to the fact that I should do anaesthetics, and that I shouldn't do. I think he was trying to say don't do surgery, which of course, you know, never tell your children what they shouldn't do, because they're going to go and do it. But it's something because work-life balance, and like I say, my dad was really old school surgery, did it all by the book, and surgery is like a calling, it's your life commitment, and I'm not disagreeing that it's not a big commitment. What was I saying? So he really played it by the book, but now there is a shift in culture. And when I was trying to get on the program, if you said your priority was family and then your career, if you said anything other than career orthopaedic surgery, because I was trying to get onto orthopaedic surgery, was your number one, a death, absolute death. You would not get on the program, forget it. And I don't think that was necessarily because everyone felt that, but there is a little bit of gamemanship and saying the right thing sometimes. But now it's so much more of a culture shift towards work-life balance, flexibility, And it's obviously important to women, especially if you're in this situation, but it's equally important to the guys as well. Like, they've got even more to gain from, because, you know, historically I think a lot of them haven't even considered that they could be more involved in stuff outside of surgery, and they could have more of a life. Yeah, and certainly, you know, look, I sometimes feel a bit sad for Dad, who just committed his whole life to it, but really at the end of it, when he reflected, it wasn't the one thing that had given him the most. So, and I think there is, in this last 10 years, to my mind, there's been a really big shift, and it's becoming more and more of a talking point, and it's completely acceptable now to say that, you know, your family takes priority, which is really big step forward. So yeah, so when I started out med school and we started our clinical practice, you know, I ended up at St Bees, and it was very alpha male dominated, lots of, you know, particularly in the surgical units, and there was definitely the golden boys that were kind of the favourites, who got all the opportunities and were really brought through to continue on that culture. And I kind of opted out and did my intern year in Ballarat, and started off with a surgical rotation. So at that stage, I didn't think I was going to do surgery. And I had a fantastic female registrar who was just about to finish her general surgical training. It was her last rotation. And I guess she was a little bit inspiring for me. And I found after not doing particularly well in med schools, that actually I did really well on the job practically, and was probably, you know, was super into the job and very, very conscientious. And at the end of that surgical term, one of the consultant surgeons kind of pulled me off for another one of these "I'll give you some advice" chats. And I actually thought that he might be saying, "Oh, you know, you did a good job, and if you ever want to do surgery, I'll give you a good reference," blah, blah, blah. But it was, "Oh, look, you know, I can see that you really like it or whatever, but and you're good, but lifestyle-wise, as a woman, just don't do it. It's too hard. Family, yada, 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 all that kind of stuff." So that kind of just really pissed me off more than anything, and probably drove me more to get going with surgery. But yeah, I then just happened to get a resident job doing orthopaedic surgery, and for the first time I had a female female consultant that I was working with on the unit. In all the other rotations I did through my internship, I didn't have a single consultant boss who was female. And that probably was a turning point, because I got orthopaedics, made sense to me, I liked it. But to see this consultant surgeon who was really great at her job, I think she might have been pregnant, or shortly thereafter was pregnant and started her family. And just to be able to see that role model and realise that you could do it was great. And to have someone that you could chat to and talk about life issues really was what kind of swayed me, and that was when I kind of headed down the orthopaedic pathway, albeit with a lot of self-doubt and concern still about it. So the training, I think I already touched on that. I found, so it was 4 years of training as on the program was to do the orthopaedic surgery, and that was full on. And for that period of time, those 4 years, there really wasn't a work-life balance for me. It was I was chronically tired for those 4 years, and I did, on the program I was sent down to Hobart for the first year, then 6 months in Ballarat, 6 months in Bendigo, then I had 6 months which I had applied for in Portland, Oregon in the States, which was really cool, but that was like 2.5 years then out of Melbourne. And then the last year and a half I was back in Melbourne, but we were kind of really gearing up for the final exam. So I was single for most of that time. You know, I think I had a couple of dodgy boyfriends that if I'd been in a better state of mind, probably wouldn't have spent time with them. But so that, you know, look, that was not an easy time, and things have changed a little bit because now there's like a minimum of 3 of you have to share the on-call. When I started out, it was the first 2 years with 1 in 2 on-call. So the awareness about safe hours and things has definitely improved rapidly over the last few years. Yeah, so having completed my training, there is a bit of an expectation and this understanding that there's still a little bit of snobbery about going and doing a fellowship. I didn't want to go overseas once I'd finished because I'd already spent so much time out of Melbourne. So I hooked up with a... It's not that. So there's another female orthopaedic surgeon who does foot and ankle work, and she's head of unit at Maroondah, and so I actually went there and kind of did like a fellowship under her where I had clinics at the same time as her, and our theatres would run next door to each other, and that's how I kind of specialised in, or subspecialised in foot and ankle surgery. And at that point, yeah, I vowed part-time only, so I was doing part-time work, and honestly I was living the dream. That was like the happiest period of my life. Yeah, and I was by that stage mid-30s, like I was 35 when I finished, which probably sounds pretty old. But I decided to prioritise what I'd always felt was actually my #1 thing. And yeah, you know, dating is a numbers game. It was just a priority, and I got lucky. So yeah, so things on that front also worked out. Not that, you know, not that I don't want to say that having a family is a #1 thing or whatever. It's just, it is an important thing for some people, but it's also not the be-all and end-all. I don't want to kind of be giving that impression that I think that. So I reckon it's about 50-50 now, just to talk more on a women's front, of how many women have their kids before or during the training program and how many would have it afterwards, if I just look at orthopaedic surgery and women doing it. So it's about 50-50. There's quite a few on the training programs that also have kids, and I can't really talk about that experience. For me, it was helpful to be able to be very selfish and just be single at that stage. Honestly, at this, there's seasons for all different times of your life, and at this point in my life, it isn't realistic for me to aim to be the top of my field. But I take my work really seriously. I'm very professional about it. I feel like I generally do a good job for my patients. But then I also have time away from work. I work 2 days a week. Those 2 days are incredibly fulfilling and challenging, and they can be stressful, but really they are enjoyable. And then I have downtime, and I have time where I'm, with my daughter, or I'm, just doing mum stuff or whatever. And I still make enough money to be able to. And I never really thought about money when I was going through, but it's really handy. And I have enough money to pay for a nanny in between, to go, splash out on whatever, or and I actually think I'm in and there's still lots of opportunities. I want to pick up this many sessions or drop those, if I decide in a few years to do private practice, or, and if as a lot of women do as well, and some men do too, if I want to go overseas and do further training later down the track, like a lot of women will then, the family will go away for a year to England or whatever, then there's those opportunities as well. So I'm not saying that it was an easy road, but I would say it's a good spot to be in at the moment, for me anyway, I feel. Because there's just so much opportunity, really. It's not, I think that's about that's about all I have to say. I think I talked. Was that too much talk?
That was so funny as well. Do you mind answering a few questions?
No, that's fine.
So we'll take a few more questions from the crowd if we have any. Anything at all?
Probably revealed too much already.
Do you have a question?
How did you pick ortho?
Oh yeah, it was just so I loved the fracture clinic. I loved the when I was going through, we were residents and we ran the fracture clinic, and I loved doing the plasters. I loved the quick throughput. It was the opposite of medical clinics where you sit down for ages and it takes so long to sort out the patient and they have so many problems. It was like, broken arm, you look at the x-ray, okay, I can see what's going on here, I know what we have to do, it's usually pretty simple, and then you do it. So it was, and I guess I do like that kind of mechanical thinking, and I've always been quite good at the 3D thinking and that type of thing. So it was that. It was seeing a role model that I could actually relate to, because otherwise, all the alpha males and stuff like that I was talking about, it's just a world that I can't fit into at all, even if I wanted to. And yeah, it was probably also the first job where I had consultants there who said, you should do orthopaedics, you know, and they said, oh, we need more women in orthopaedics. I didn't get this kind of crap of, oh yeah, so you could do surgery, but I don't think you should, it's not good lifestyle choice, la la la, you know. So I think it was just a kind of a meeting of the stars, basically, if you know what I mean. It's just kind of all aligned, yeah.
So my question is, can you tell us a bit more about your mentors that you had throughout your training, and also maybe in school, in med school, if you had any mentors or people you looked up to?
Yeah. Oh, I was thinking about this the other day and I can't remember what I decided. Who is my mentor? I think, yeah, to go back to that female orthopod, she was definitely a mentor and encouraged me throughout and helped me with doing a little bit of research. And through school, yeah, I don't know if I can think of anyone through school who would have, I guess I looked up a lot to my dad, and I think over the years I've seen things in a slightly different light, but yeah.
In terms of orthopaedics, is it still a very boys and their toys sort of environment, or are you finding that it's getting more and more like everyone's included?
Well, it's certainly become a topic now, and the AOA has actually come up with a plan of how to get more females. So they're starting to set specific targets, so not mandatory numbers, but to at least have the discussion, set targets, have that awareness of diversity. So there's still the big problem of culture. So there are a lot of old guys doing orthopaedics still, and their culture is just, you know, none of them would say that they're sexist, but it's so ingrained in the way they've been brought up that they don't even notice it. They say stuff and they don't even realise that what they're saying is sexist. And so AOA is at the point where it can have a conversation about that and recognise that there are cultural problems and say, we need to change this, but the feeling is that it's going to take a little bit of time to wash through. But the female numbers are increasing pretty rapidly now in these last few years. And I think once you want to get the 30% females, then they'll change the culture just from being there. So I think that's how it's going to pan out. But just in general as well, like the boys and their toys type of thing, I mean, if you go, so money is where it's at. So it's all about, if you have a look at the prosthetic companies, they're the ones that are, you know, where the buck stops type of thing and that are making the money. There is still some of them who are just, if you look at their advertising, just targeting men. It's all really, you know, Formula One driver type ads for orthopaedic prostheses and implants. But there is also another shift that we're seeing more, which is these like, so we're talking about total knees, total hips, which is big bucks, that are actually becoming more interested in the psychology of the patients and targeting that area. And so there is, they're also kind of changing their culture a little bit as well. So, you know, there's been, worldwide, there's a bit of a, you know, the Me Too stuff. It's all is starting to flow through, and orthopaedics is definitely not immune to that. I mean, inclusion is really important. I was thinking on the way here, when I started med school over at that other place, like I'd say half of the medical students were from a handful of schools that were all private schools. It's just incredibly, non-inclusive, but it's changing. We need that for innovation. It's just, yeah.
How long did it take you after graduating?
Yeah. So it was 10 years. So you mean from intern or from resident or whatever? Yeah, I think it was about 10 years. I could have done it a lot quicker. I did take some time off. My second resident year, I went overseas and just did travel. So, yeah.
Having a dad as a surgeon help you anyway?
Yeah. So, and to me, that help was. So look, I came from a medical family where Dad was one of 9, and 3 of them four of them. 3 became surgeons and 1 became a rheumatologist. 2 died before I started medical school, if I include my dad. The rheumatologist would have nothing to do with us after my father died, and the other one was struggling with mental health issues and also was not involved. So once I started medical school, I didn't have any medical family person that I ever talked to, if you know what I mean. But having that background where it was like, and I still, it's a double-edged sword. I did, at St V's have people say, "Oh, are you such and such as, daughter, or are you related to whatever? Oh, you're one of the Lenaghans, blah, blah." So for me, it was that little bit of confidence, I think, of being able to identify as a kind of medical person, if you know what I mean. But I don't think I got any favouritism resulting from it. Who knows? And I didn't actually get any kind of personal type of mentoring from anyone after I joined, started as a medical student. Yeah.
Alright, so thanks so much. And let's give her a big round of applause.
Hey guys. Our next speaker is Dr. Stewart Morrison, and he's an orthopaedic surgeon at the Royal Children's Hospital. He's on the board of directors of the Victorian Doctors Health Program and is a clinical lead with the National eHealth Transition Authority. He's also worked with AMA Victorian Doctors in Training as a vice president, and in his own time, Dr. Morrison is an avid photographer. He also has a keen interest in doctors' health, mental well-being, and work-life balance. So please give a warm welcome to Dr. Morrison.
Thanks, everyone. Sorry I was running a little bit late. How do I make this PowerPoint later? Oh.
Yeah, it's on their desktop.
Oh, sorry. Oh, yeah, perfect. Thank you. Okay. So that biography, thank you for that introduction, is probably a little bit out of date now. I'd have to laugh whenever I wrote that and added the work-life balance advocate at the end, and now I'm doing this talk here. It's a little bit ironic, but I maintain you probably still can have work-life balance. So rather than talk too much about myself, which I'll get to, I just thought I'd lay a little bit of the pathway out from where you guys are at the moment in medical school to, I presume we've got a range of year levels here, do we? To finally finishing surgical training, which for me was orthopaedics, and how we get there. And some of the things and practicalities that they don't tell you along the way. So what am I going to talk about? Well, how did I get into training, or how do I get into training in general? All the little steps and bits involved, it changes from time to time. What surgical training is like on the ground, which I was doing up until very, very recently. And then making the most of the journey and seeing other bits and pieces. How do you know you want to do surgery? Well, as a med student, just experience it. So the good thing about medical school, as you know, is you get to sort of see things and do things, and while the residents and interns are running around on the ward and sorting out paperwork and doing a lot of administrative tasks, you have the opportunity to go to theatre and see things. And in some hospitals, that is the most surgical exposure. If you take advantage of the rotations, you'll get until you're at a junior registrar type level. I did not make use of my rotations when I was at uni. In fact, when I was at uni, I had a very different experience to those interested people who are in the room here. I could think of nothing worse than doing surgery, and had it bottom of my list in terms of specialties to do. And I think I went to one ward round in final year on my surgical rotation. So I think I scrubbed for one Caesar, and that was it in the sink in medical school. But don't do that. As a junior doctor, get the most out of it. So then your priorities change a little bit. It's more about managing that clinical workload, fully learning out how to be a good doctor prior to thinking you're going to want to become a good surgeon. And that's about being a team player and attending theatre and all of that, which we'll get to in a moment. These are the 9 surgical specialties. Gone is the model that your colleagues or parents or friends have talked about from years ago, where you do sort of general surgery training and then subspecialise. Physicians still do that sort of BPT thing and then go into their advanced programs. It's different in surgery. So even as a service registrar, or unaccredited registrar as they're called, you really will be working on one of these 9 specialties. People that once this program came in about 8 years ago, there were some people who did still flip-flop back and forth a bit, or get into general, hoping to get into a more difficult to obtain training program such as neurosurgery or plastics. It very rarely happens now. The system is not really set up for it. The good thing is, because you're going to do a number of years as a unaccredited registrar or resident, you get a really good opportunity to get around and see what rotations are available and what it feels like to work in them versus being a medical student in them. And that's something that I certainly would hope informs your decision about where to go in intern year. The honest truth of intern year is everyone likes their job, and about 90% of people stay under that hospital for their second year as a resident, even if they're in the country, even if they're in the tumour centre in the city or the regional hospital near the city. Everyone enjoys it, and what I would do is talk to people who are currently in those jobs and work out what rotations you can do as an intern, what rotations you can do as a second year. Certainly things like Opthal, which is obviously not in this specialty group, but ENT, surgery, urology, vascular, there's less junior resident positions. So if you want some exposure to them, pick your hospitals based on where those rotations are. How do you get into training? Well, everyone thinks it's all about learning anatomy at university and then getting your stitching and everything up and going to theatre. It's really not. Remembering that the way they pick people to be trainees is based on a set of competencies. That's the AOA list, and the RACS list is there. They're pretty much the same thing repackaged. AOA is the Australian Orthopaedic Association. That's why I keep referring to it as one of my bodies. So when you're setting up how you map your development, how you think about what are the skills I need to acquire to make myself selectable, to then become a good trainee and a good surgeon, think about all of these areas. It's not just about that little small group down the bottom there of, where is it, technical expertise, meaning how you can suture. And these often map directly to interview stations. So the year I interviewed, there was 9 interview stations, and each of them was actually mapped to one of these competencies. So they're all clinical stations, but they wanted you to demonstrate some knowledge in the specific area, which is very helpful if you could read upside down, because you can read it on the interviewer sheet which station it is. Getting into training is a combination of, they look at your experience, exams, application and interview. All these training programs now have a centralised application system nationwide, even if the training programs are regional or network based. Experience, you have to list everything you've done in the past, your unaccredited registrar years, exams. Now we live in an era where the GSSE or Basic Surgical Science exam, which is the same for all surgical specialties under the RACS banner, needs to be sat and passed prior to applying for training. You need to apply. When I went through 4 or 5 years ago, you could only sit it once you were on to training. And again, that moves back and forth, so check it. That's a big exam. It's 3 to 4 months of full-time study while you're working, so it's not to be underestimated. You're all smart, you've got into med. It's very expensive for the university to fail you and make you repeat a year in medicine. This is the first exam that you will actually have to proper study for. You've probably cruised by now, even though you don't think it and you're all pedantic and everything. Trust me, this is the first exam you think, oh no, this is actually going to be quite difficult, and you'll know what the other 98% of the population feel like at every exam they sit. Study, sorry, I'm not being, you know what I mean. Study group's important because you will be, again, studying while working. Study group is not so much at this level good for the 1 hour of giving each other really boring PowerPoint presentations that week. But what it is useful for is giving you a deadline every week. If you're studying and working, it's so easy. You're too tired, maybe tomorrow, too tired, maybe next week. Then suddenly the exam's upon you. And study group means that no matter how tired or busy you are, by Sunday night or by Wednesday night, you have to have read this stuff or chuck this stuff into a PowerPoint, because then your 3 or 4 friends in that group will be disappointed because you haven't done it that week, and you don't want to be that person. So that's where study group is important. And it costs about $3,500 or even more now to sit this exam. So you're working. That seems like an insurmountable amount of money as a medical student. It's not as any work. It's annoying, but it's not undoable. But it means you don't want to have to do it 2 times or 3 times. Okay? So do it once and do it well. Then you apply. There's a common RACS registration you have to do in February, which every year a few people miss out on. That's about $400. And then you apply to your training program of choice, and that's about $600 or something. The dates are not negotiable. Any of these steps, you're behind like 6 hours in submitting it, see you next year for the application. And the application is quite a lot of formal paperwork to compile. So you need a transcript from university, which when you get your degrees at the end of this year or next year, is a formal university transcript, and it's in the back of the bag. They put your rolled up degree in, and I didn't even know it was there until I found it one day when my degree is still rolled up at my parents' house. I haven't framed it or done anything yet. But when you can't find it and you don't know and your parents aren't home to check where it is, and you're ringing up and you need to ring the university to get a new transcript, and they tell you, oh, there's a 28-day turnaround, and the desk is only open for 2 hours on a Monday or something, suddenly these time frames become very clear. So get very, very organised well prior with this application stuff. Then there's a whole lot of other things you need to do. So you just need to tick all these boxes off. Like if you're a New Zealand resident, that's slightly different. If you have medical registration, slightly different. And then there are these other learning modules. So just get on the website and read it. And it changes year to year. So read it now as a map, but then in a few years' time, have a look a bit closer. The application, you have to do referees. Again, that varies from year to year about what that involves. The referees are almost all blinded, so it's not about who you know, it's about how they see you in the workplace and everything, and that's why it's really equalised. You don't need to go to the Alfred or St Vincent's or Royal Melbourne to be the next neurosurgeon or the next general surgeon. It's a level playing field. I was mostly at the Western, which is about 6th on my preference list. I got the Western as intern year, loved it, stayed on as a resident year. I recommend anyone goes there now. It's a great hospital. And although I got on from Dandenong because I got on my second attempt at ortho, I credit the Western with supporting me and getting me through that period. Then there are all these other bits and pieces, and these are big documents, so don't trouble yourself with it yet. This is just painting a bit of a quick picture of what goes on. So there's all stuff about research. You can't get something published in the New Zealand Medical Students Journal anymore and then claim 7 years later that it's a reasonable publication. There's some different programs have things around the impact factor of the journal or this or that or the other. Bear in mind those. Presenting things, similarly, skill courses, points for things like that, and you need a retrospective letter, so it's no good sending a letter from your hospital saying these are rotations that Samantha is doing this year, You need a letter at the end of the year from a medical workforce saying these are the rotations that Samantha did this year. And depending on which letter you send in, could invalidate or validate your application. This is a complaint I hear commonly from trainees and from people trying to, and they keep changing the goalposts. Every year they amend these. Sometimes the anatomy diploma is worth 4 points, sometimes it's worth 2 points, sometimes research moves and whether it's published or accepted for publication, and people get really whingy. It is frustrating if you're doing those things, yes. But remember too, another way of thinking about this, I have to keep doing things that will make me a better surgeon. So the reason you're doing an anatomy diploma, the reason you're doing research, hopefully is because you think this will enhance your practice and ability to be a good surgeon, and it's in the areas that you enjoy. I had someone come up to me once at one of the career fairs in Melbourne saying, just give me the lowdown, tell me the quick pathway to get on. I'm like, well, there isn't one, and nor should there be one. And every time they come up with a system, people eventually find a way to game it. So by changing a little bit each year, it keeps it a little bit more level, I feel. You're going to be working until you're 60, 65. You're also young at the moment. Another year or two spent doing things that are going to enhance your career anyway is not a bad thing in the scheme of things. If you're looking for a quick fix and you want to get on next year or don't want to do it at all, it's probably not the career for you. References, so the interns and residents that get good references are the ones that run a ship-shaped, perfect surgical ward, a very organised follow-up on tests and investigations, follow-up on results. The consultants look like, and you've probably experienced this, most of you on clinical rotations by now, that you feel like the consultants are never there and don't have any idea what's going on the ward, and you barely see them and they don't know your name. Trust me, as a consultant now I can say this, but I saw this even as a registrar, you know when the ward is a mess. You know when things aren't running well because it filters up. And consultants have been registrars. They know what happens and what goes on. Consultants have been interns and know what happens and goes on. And a well-run ward really reflects when the registrars are calmer and everything's running more smoothly in theatre. Patients aren't getting sent back because they haven't had bloods and x-rays are ready and everyone knows what's going on. Patients end up in the right clinic for consultant follow-up. It makes a difference, and the resident or intern that runs a really well-organised ward keeps the NUM happy. The NUMs are always calling the consultants about different things. Is far better considered than the resident who leaves the ward in a mess but tries to turn up to theatre and display anatomy knowledge and everything all the time. Okay, it's good to get to theatre, and once you have the confidence of the ward, the confidence of the nursing staff, they know you're good. They know you'll do tasks when you come back to do them. They will then cut you some rope to go to theatre to write jobs on the board rather than call you every 5 minutes with another little task to do. And that's the rapport you build within your team of residents or interns too, that you have one day when somebody does all the ward work and someone goes to theatre and you vary it around. Encourage feedback and act upon it, and not only in your suturing and technical expertise, but all the other areas as well. If you get feedback about your communication style, act upon it, do something, reflect upon it. Interviews, so my advice would be do as many interviews as you possibly can. Even though you may choose to stay at your hospital in second year, apply for the 6 closest hospitals to you, just so you get 6 free interview practices with 4 more people. It's cheaper than doing an interview course, and more realistic. And that applies at all levels. They're all just really good practices, because you will find times in interviews where you do go into them nervous. You will find times you get asked a question you just don't have an answer. You need to be able to manoeuvre in that situation. So it's best to have practice. Sometimes interviews are very clinical, and they vary even at a surgical application level. Sometimes they're very clinical, like you've got a 5-year-old with a supracondylar fracture and this is the x-ray, how are you going to manage it? Sometimes they're very behavioural. So there's a clinical one used in the orthopaedic interviews from a few years ago. And although that sounds clinical, talking about scaphoid fractures and the various methods of how you measure displacement and MRI and this and that and the other, it's really not. The clinical stuff's a side salad. It's more about professionalism and communication and reflecting on your practice, because you've got something that's been missed or a clinical incident. So the person who charges into that and lists the 7 most recent papers on which screw to fix the scaphoid with will fail that sort of station. And then they go to these more behavioural type questions. So this was an interview question last year, interestingly, which I think is probably on the borderline, but nevertheless, the way they marked it was such that it was actually a very good question because it encourages people to reflect on their own experience and think about the ways in which they've dealt with problems in the past. It's from a different presentation. So what is training like? You don't just operate, you do a whole lot of different things. As you can see, the operating is not just the cutting, but the planning and the managing and the following the patients afterwards and reflecting upon how they've done. Was that operation a good idea? What could we have done better? You're in clinic and you're on call. And so many of those parts, it is all about communication rather than actual technical skills. This is also what on-call's like sometimes when you're scrubbed on a Saturday and you get away from your phone and you look at the screen and you're like, oh my God. And then this was before visual voicemail, so when I called the 101, I had voicemails from each of those with different things going on. It's not always like that, but it is sometimes like that at hospitals. And by teaching yourself to be organised early on and have a system, I have a little list. There's a text document open in the corner of my laptop screen, this is about as far from my laptop as I've been in 3 weeks. That is always open, and when people in the corridor say to me, oh, Stewart, could you actually order another x-ray for that kid we're operating on next week? I stop, open my laptop and type it onto the list, because, again, we're all very smart people, and you've gotten to this point by just being clever and being able to run at a mental level where you've been able to just take everything in your stride. The busyness you will get when you're in clinical jobs, even in non-surgical roles, will actually start to exceed what you can fit into your short-term RAM, and you need to find a way of writing it down. The amount of anatomy you remembered in a case, or the 10 things you did really well in outpatients that week, will be forgotten compared to the one patient who didn't get a group and hold and turned up to theatre and got cancelled because you were told to do it walking somewhere and then forgot about it. And that's just the nature of the game. It's all about thoroughness. It's not about sitting those high peaks. It's just about keeping the baseline misses low. Organisation is key, so often you'll be involved as a registrar doing rosters as well. Rosters are much better done in some hospitals by the clinical team. It's a lot of work setting up the spreadsheet and going through and making sure everyone's having their afternoons off and everything. But if you drive it, then you control it, and you can ensure people do get their afternoons off. People do get to the operating list they want to see. People aren't hogging other operating lists. Even as a resident or intern, workforce will often give you a fairly basic roster. They're pretty inflexible with changing hours and things, but if there's ways in which you can mould it so more people get a bit of clinic exposure or a bit of theatre exposure, that's a good thing. And if you drive it, you can control it. On call rosters, again, if you set that up in advance and get the confidence of the medical workforce person and of the secretary in charge of your unit, that then gives you the flexibility to organise the swaps yourself weeks in advance and get to the friends' weddings, get to the weekends away, get a weekend off either side of your annual leave so you've got another 4 days then. They're all the little tips and tricks to get time, and by being organised you then have the time to do all your other life things that you need to keep doing. There's nothing workforce hate more than getting emails a day out or 2 days out, or can you swap with me today? And when switchboard get a call saying, oh no, they're not on call today, this person's on call, switchboard then panic, they call the consultant, the nurses don't know who to call, then the head of the unit finds out, and then everyone gets in trouble. That's what you don't want to happen. How to not annoy people. Be on time, follow up on things you say you will, clean up after you're on call, that's probably a little bit, I'll think about that in a few years' time. Be flexible as crowd, don't be a martyr, so don't be that person that says you have to hang around and have to do all this work and you're there till 9 p.m. every night if there isn't a good reason to. But on the other hand, be flexible. So occasionally you'll miss an afternoon off. That is the nature of doing surgery. But on the other hand, if you've seen your colleagues been up to 3 a.m. operating and is absolutely ruined because they've had a horrific on-call, you can say, hey, I'll do your list tomorrow. I'll do your list this afternoon. You go home and sleep. I'll have your afternoon off next week instead. So it's that collegiality that actually gets you through, not some workforce roster that's thrust upon you. Respect hierarchy, but don't pull rank. Yes, okay. The exam at the end of this transitions into the life stuff, funnily enough, is really big, the fellowship exam. You end up studying for about 18 months. That's me with my study group there. And I'm not going to talk about the bits of the exam and everything like that because that's a long way off. But what you realise when you get to that pointy end of study, which again is an exam you actually do have to do a lot of work for, it's the people in your life that get you through. So you end up with your fellow registrars and colleagues at hospitals, you probably spend more time with than you do your own family and partners at home, at least awake time. And you get to know them really well, and they know you very well, and they know when you're stressed, they know when you're a bit off, they know when things are going well. And similarly, your study group is also a critical asset because for at least a third of the time when we had study group during fellowship examination, we weren't actually studying, we were just complaining about how much we hated our lives because we were studying for the exam and debriefing. But it was nice to open a bottle of red wine and just all realise we're all in the same situation, and all the battles we were having at home, keeping our partners happy during the exam when we're trying to study, were very similar around the table. That was down in Lawn because we were down there for a meeting. That was after the exam that was actually when we'd finished the exam but didn't get the results yet. We took all our partners to Vue de Monde, my study group, and had dinner, so that kept them happy for a few hours. And so it's being aware of that side of things as well, I think is important. That's us the day after we passed last year, all looking very happy. So making the most of training. This gets a bit more to the life side of things. I'm not sure what other people have spoken about, so I'm covering ground again. I apologise. I think it's important to get involved in things. So for orthopaedics, the two overarching bodies are RACSTA, so the college. The training association is RACSTA, which I was on for 4 years, in first communication, then professional sport and welfare. And then AOA, which is the Orthopaedic Association, which have AORA, which is a registrar association, and any of these surgical specialties will have that sort of body. I'm a firm believer, and you've probably seen this already, when you're at clinical rotations, you're at the same hospital every day, you end up with this tunnel vision, and the hospital becomes your life or your jail cell or whatever you want to call it, and you lose perspective of things outside. So even if you just have one other formal commitment, it can be medically related or not, it just is really nice to get some perspective and use your brain differently for a bit. Just going to go through a whole lot of examples because I didn't know how best to structure this. So the AOA, being orthopaedics, have identified they've got a real problem with diversity on a number of different levels. So last year I got invited to the first diversity workshop. So they're setting up a diversity strategy around mainly the gender imbalance, but also cultural imbalance and other areas. So that was the first meeting of that. And that was a really fiery workshop, as you can imagine, with people there from all different walks of life in orthopaedia. But a real good amount of stuff came out of it, and that's been now progressed to policy, and we've been asked to help rewrite it. So yes, that's an area that certainly the College of Surgeons and the AOA specifically as a specialty has a long way to go in, but things are slowly turning in the right direction. That's the RACSTA board at the college at the end of last year. They're all trainees, and Ruth Mitchell at the front, she's amazing. She's a neurosurgical trainee here, just finished a PhD. Under her guidance, we made a hell of a lot of difference with RACSTA and got really people high up in the college listening to us on a number of different issues and fronts and things going on. And it's really powerful when you're a rep on some of these committees and you get sent along to college council or to something, and these very, very senior people in these colleges are actually listening for your opinion and they want to hear it. Other parts of the college that maybe are a little bit more than the old sort of boys' club that you would imagine. There's the Aboriginal and Torres Strait Islander Health Action Plan, which is being pushed very strongly at the moment, due for a rewrite soon. The college have their own diversity and inclusion plan. There's the Women in Surgery division of the college, to which anyone is welcome. And there's the Orthopaedic Women's Link, which has now been instigated in the AOA, which is also a good group to reach into for that diversity side of things and how we're going to affect change. There's a section of academic surgery and surgical research in the college. So if you have an interest in going into a more academic role, you can make connections with them very early on. You can meet other surgeons who are academically minded or have set up situations where they do 50-50 clinical and research. All those things are achievable. The Foundation for Surgery do a lot of outreach work and international work and a lot of funding of projects overseas. that's an incredibly rewarding service to get involved with too, if that's the reason you got into surgery. There's a tweet from Rachel Kerr. She was on the board of RACSA last year. She's a final ENT registrar from New Zealand. That's her with her 3-month-old son breastfeeding between cases just after she went back to work. Again, one of the major issues with surgery has been the flexibility of training, or the inflexibility. What that's meant is it's turned a lot of women away from doing surgery, and it's also meant, probably to a lesser extent, but just as bad, it's meant a lot of men have missed out on being involved with the family just because of cultural expectations and a whole lot of different factors. That can be changed on both fronts, and with people want to have kids or want to be involved in their kids' lives as they're growing up, that is now more easily achievable. There are flexible spots becoming available. The AOA's looked into it now, and a few trainees have done that in Victoria. We still have a long way to go to catch up with most other industries, but the wheels of change are slowly turning. And there's a number of very strong trainees who've gone before in the last couple of years, to which we owe a lot in terms of those changes happening. The college is now listening. You also get to do other things in training. So I said before, I wrote that little spiel about work-life balance, I think, when I was probably in 2010, if I was involved in the AMA. But since then, in 5 years of surgical training, does anyone know where that is? Don't expect you to. So that's in India, where we went a few years ago. If you're into your architecture, you'll get all these. Any of those? Anyone? So moving around to the top, that's in Iceland, that's in La Défense near Paris, that's in Moldova, if you know where that is, and that's in Berlin. That's the Empire State Building. Where's that? Chernobyl. Good, yes. So you can get there in training if you want to, though they don't have conferences there. That's in the former RLC in Kazakhstan, where I went in 2013. And that's my dog, who was my main study partner. So that was the other thing. About 6 months out from the exam, my partner cracked the shits and decided that we needed to get a dog. And I was in such study mode, I said, this is probably the worst possible idea right at this point. It's stupid. But anyway, I caved in the end after a deposit was put down on a breed of dog I really didn't want. So I retreated and managed to settle on one that I did want. So we ended up with this little Italian greyhound that I just wanted a short-haired dog that would run, so I could take it for runs, because I enjoy my running. And that was probably the best thing that I did to help manage my stress during the exam, even though I hated the thing initially, because it meant that when I had a break from study, I wasn't sitting on Facebook or sitting on my computer mindlessly. I had to go and walk this thing around a park or go outside. But that was a real big change, and I think that actually helped a lot more than I gave the dog credit for at the time. That's Apollo. Other things in training, so they're all the organisations I've been involved in, formal ones up the top, more informal things I've had memberships with or done during training down the bottom. I ran the Doctors' Health Conference in 2015. I was involved in the Victorian Doctors' Health Program. I'm involved in a German exchange organisation, which is a nice different area of the brain thing to do. I'm also a Platinum Icon member of a certain musician's fan club, which is the top ranking tier, which meant I got to sit where that red circle is 2 years ago. And the surgical training is incredibly rewarding. So it's such a, the difference you get to make, the opportunity to be the one making that difference in a lot of these patients' lives is just incredible. I'm very simple-minded and I need a quick bang for my buck return-wise, not meaning you come in, things are broken, you fix them, the patient can walk again, which is just such a good feeling, and everyone's very appreciative. And all the complexity and the hours and the planning and the stress and the admin and running around suddenly becomes worthwhile when you get those outcomes. So this is a 12-year-old who came in when I was in set 1 off a motorbike, and this was the first X-Fix I put on by myself because everyone was at a conference, and the boss in the next theatre said, just go for it, just put a frame on it. So that was hairy, but then the boss obviously realised how stressed I was for the next theatre going through all this. So when I'd moved rotations, 6 months later sent me a photo of the fracture healed, and this kid had stuck his UR stickers all over himself and standing up on 2 legs. You can see my little pinholes there in the tibia. And now I'm at the Royal Children's Hospital, managing the congenital limb deficiency and sarcoma tumour work, which is a big workload at the moment for me, being 6 weeks into consultant life, and they're incredibly complex patients. That's a kid up there who's had a sarcoma chopped out, and plastics come in and do a free fibula from the other side and plug it into the profunda to build an A-frame, and then we've put a nail up it to hold it all. So that's about 16 hours of operating. We've done 3 of them in the last 6 weeks. But it's good work because you are seeing these kids now, and I've got a clinic every Thursday. So we're doing, on one hand, we're managing those in theatre. On the other hand, we're managing these kids on the ward who've got wound breakdown. You think sick kids are grumpy. Wait till you deal with sick kids on chemo and their parents. It's absolutely awful. But then you see the ones that are 2 or 3 years after the operations and treatment coming into clinic, and they're back surfing and playing soccer, and their biggest complaint is that one leg's 2 centimetres shorter than the other, and they want something done about it. So it's just such rewarding work, and I think that's one of the things we have in medicine to hold on to. I think just between you and I, that's one of the things that we get as doctors, and a lot of the other people who work in hospitals don't actually get that opportunity to get that gratefulness and thanks from the patients. And I think that's something that we should feel really appreciative for, that we're the ones at the end of the line that make that difference for the patients a lot of the time. And it's Apollo asleep again. Good. Any questions? I wasn't sure exactly how to pitch that talk. I wasn't sure whether you wanted sort of a very self-congratulatory biography, or you wanted more information on how to get into training, or what it was. So if there's any... Yeah, go ahead.
I know that being a registrar is pretty messed up in terms of workload, but I guess when you become a consultant, has it changed dramatically in terms of work-life balance?
No. So, not for me, but as you can see, I've got trouble saying no to being involved in things. No, it's a different sort of stress. We've been talking about this about my study group. It's still very stressful, and I'm finding it more stressful now operating because I'm making my own decisions, and I haven't got someone patting me on the head saying, "You're doing good, you're doing good, you're doing good," as you do as a registrar. And it's still busy. Like, I set up my year this year as I'm doing 3 days a week at the kids and 1 day at Dandenong, split into 2 halves. So I thought, that's great. I filled 4 days. I should have filled 5 days, but I've got a little bit of on-call, so I was supposed to have a day free a week. I haven't had room to move this year, and that day a week I've had free, I've usually spent at the kids managing all these sarcoma patients, sorting them out. And you do end up, I get into work at the moment at about 5:30 in the morning, and I'm doing paperwork and sorting stuff out. That's because I don't like working late at night. Some people are much more night owls and like doing all their study and work at night, whatever works for you. It's not ever going to be a job where you can work 9 till 4:30 predictably and go home and do things. It is getting a lot better, and the American model of just absolutely smashing you from 5 a.m. till 10 p.m. for 6 years, the best years of your life, is wrong and unsustainable, and we're moving away from that here. But it does get busy. You need to keep your friends and your partner on board with the fact that sometimes it's just a bad day, and 5 o'clock will become 7:30 before you know it. And that's where you need to have some flexibility with your colleagues about how things work. You, even doing part-time training, that will still happen when you have a list that runs over or something like that. And your partner gets a bit sick after a while about hearing these tales of woe with this poor patient with a broken leg. They just don't care anymore. So does that sort of answer your question a little bit? It is busy, but you find you enjoy being busy. And there's that old adage that gives, if you want something done, give it to a busy person. And I find at least people say, how have you done all this travelling? How have you done all these other... You're just so good at going and organising and moving that you get to... It rolls into your holidays, and you're able to fit stuff in and move stuff around and be strategic and get things done. Yeah. Any other... Yeah.
Are there specific hospitals you recommend to going for an internship?
For surgery, no. For ortho, I can only speak from experience. So most hospitals with an orthopaedic unit with their unaccredited registrars will pick from the residents, and it's good, at least one of them. So I think it's good to make that transition in any specialty from resident to registrar in the same hospital, because the steep learning curve is steep from resident to registrar. And if you can do it in an environment where you know people, you know where everything is, you know what an X-ray form looks like, and you know sort of the system and the bosses, it eases that transition. Specific hospitals, I think everywhere's pretty good. Now that they've anonymised the referee system, so it's not about who the surgeon is, it's about how you've gone as a trainee, it's really got a lot better. Certainly there's hospitals around which don't have neurosurgery or don't have vascular or don't have orthopaedics, some of the country ones, but I'd hesitate to recommend anywhere. I was at the Western, it was excellent. I'm now working at Dandenong. I've seen interns who are now up and got onto the program recently. So most places, to be honest. Yeah. Yes?
As a medical student, I've often found when I've done rotations with surge teams that they're pretty hectic because like, the reg is always in the theatre and then the residents have lots to do. Do you have any points on like how to best be a useful part of the team and also how to like learn the best that you can and not kind of get stuck?
Yeah, meaning being useful as a medical student or as a... It's pretty hard. Just don't like actively do damage or get in the way. No, look, it's about helping out, and I don't know how to answer that. Look, what you realise is that you look at everyone and everyone seems very stressed and there's a lot going on all the time, and you start off all these roles thinking you're going to be able to reduce that stress to zero just by being more organised. And I got to a point of getting in earlier and earlier and earlier and staying later and later, thinking the more work I did, I could get the whole thing organised and make it run. But I sort of came to this epiphany where I spoke to one of the senior registrars and said, is it always like this? And he said, yes. It's always this baseline level of chaos going on. And after a while, you just become comfortable with that and know that that's sort of how everything's moving forward. And if you have the mechanisms for addressing the safe stuff, the making sure bloods are done, making sure stuff's done, at a medical student or intern level, the best thing to do is just start with a list. And as boring as it sounds, checking that every patient or every hip fracture patient's had a set of pre-op bloods and has a group and hold, and every post-op patient leaving's had a post-op x-ray. Its thoroughness is really rewarded because as boring as that seems, when you identify the one or two that have slipped through the cracks and flag it, you've suddenly solved a whole problem because you've solved the first hole in a big bit of Swiss cheese that could turn into something quite dramatic. So in terms of what you do directly, I just ask the residents or interns, what do you want me to do? And it's not always putting cannulas in or going to assist in theatre. Sometimes it might be helping with discharge summaries or just printing lists and sorting out the photocopier stuff. Like, it's just about, and by doing those tasks, they see that you're interested, you help take the load off them, their load's slightly reduced so they can dedicate more brain power to actually teaching you or showing you something interesting because they've got an extra 3 minutes of time. And that's where the trade-offs and learning happen, I think. So people who, and I've learnt this now, I'm now in a consultant role and I'm much more stressed than I was as a final term registrar. When you're stressed, you can't teach. And so you can only teach when you've got enough mental reserve to do so. So if you can do something that aids those doctors just above you, you're much more likely to get some teaching out of it. Yeah. Other questions?
You described it a bit as sort of superhuman level of organisation, which worries me a bit as a first year. So it's just...
No one's this sort. No, I get in trouble when my partner finds I've made Excel spreadsheets for weekends away. So I have to hide the spreadsheets and pretend I'm doing everything like off the cuff. I'm probably I'm the wrong person to ask about that because I just like everything written down and in boxes. That's why I like big concrete square architecture. I find it calming. But you do need a baseline level of being organised. Some of it just comes with getting more busy though. Like, it's silly if you're in first year med to be running at that level of organisation. But the times to start doing it when you start planning towards an exam and studying, and then in your rotation you'll see a list work. The main game is though when you hit the hospitals and start working. So don't feel you need to be a major stressor now. Don't feel like you need to be doing heaps of anatomy diplomas, online courses and sucking up in hospitals now because you don't. As I said, I did one surgical rotation and turned up to about a week of it, if that, and still managed to get to this point now. And that's the other thing. Working in the profession versus being a medical student, the profession is very different. And a lot of my cohort from medical school have ended up doing different things to what they thought, whether that's a different surgical specialty or that's something completely different. And there's people like myself who had no interest in surgery that then suddenly went that way when they were working, and there's people who went the other way. And there's nothing wrong with that. We need people in all professions at the moment.
This slide you put up before about the few things that you do after graduation will increase your candidature. I saw that nothing was really there during med school.
Yeah.
Is there anything you can? A lot of things don't.
No, it's sort of hard, and you I don't think there's a lot you can do. I think you just learn to be a good doctor and get your communication stuff organised and your just general medical knowledge organised. And that's the other thing that rolls into that is in intern year you have to do your medical rotation and emergency rotation. Often you do 2 med rotations. Make the most of them, even if you're dead set on surgery, because that is the most medical knowledge you will ever learn. And you're going to be then running at intern level medical knowledge for the rest of your career. So make it good medical knowledge. Other things you could do, not much. I mean, if you're at hospitals and can get involved in bigger research projects, that's a good thing. Particularly if you do a BMed Sci or do something that's in your area of interest, and that for some people that's proved prosperous and they've progressed it on, very few people, to my knowledge, have got such a meaningful publication out of their BMed Sci that it's still counted and been good for their surgical application. Things move quite quickly. Sometimes things have to be in the last 5 years, which makes the time frame difficult. And I think research done early on for the sake of doing research, you suddenly find 4 years later, you look back on it and think, you know when you look back on stuff you wrote in year 12 or 11 and you think like, you were just so basic back then. And, it's sort of similar. You look back at stuff you wrote as a medical student and think, oh, God, really? Because your level of knowledge and your maturity around dealing with that knowledge has progressed. So I wouldn't stress about trying to get involved in research projects because I think the effort you expend on it versus the return you get is a little bit more minimal. But the more medicine you can learn, probably the better. Other questions? Oh, we'll go here and here. Yeah.
So you said that BMed Sci is kind of like bad timing, you're not mature enough. When did you do your research?
Yeah, sorry, I don't mean to speak down on the BMed Sci. I didn't do one. A lot of my friends did and found it helpful, but mainly just to increase their knowledge, and it gave them a bit of background in research that they could then use later on, but it's not necessarily your ticket to a landmark paper that will help you cruise through. I started mine in, again, you don't want to take anything on an intern year, you're too busy, but then at the end of intern year when I went back to do an ortho job as a resident, the heads of the unit knew I was interested, and one of them wanted to do this project on data collection, so I sort of got involved and he said, hey, you should write this up, and it just went from there. I've not done a PhD, I've not done a master's, I've not done any full-on research like that, it's been more minor stuff. But opportunities present themselves again. If you're organised, and when you're organised, you look organised, and the consultants and everyone see that you've got, because you've squashed everything nicely down, you've got this extra 30% of brain and resource that you can use for something else. And that's when you talk to them and ideas come up, and most people find they just fall into projects rather than actively going out and seeking them. So, but again, if you're interested in research, do a BMed Sci. Like, it's increasing you as a person and you as a doctor to have done that research. If I'd done one, I would have skills in that area, which I don't have because I haven't done one. Yeah.
Yeah, so is there like a particular turning point or experience which made you go from, okay, I don't want to do surgery to like, no, I want to do surgery?
For me, if you ask my story, I picked my intern rotations because we got this list of rotation preferences based on when the annual leave was in intern year. I wanted the end when I had money. So you could go away. But then, and I got ortho first up and thought, this is ridiculous. I'm going to be kicked out as a doctor. I've not done any ortho. I don't like it. They're dickheads. And then I got involved in the unit. The unit was changing over their computer database system, and it was just a shambles. And so I got in there one day because I've got a bit of an IT background as well, and I fixed it one morning. And I emailed the software engineer involved, and we nutted that because I had the clinical knowledge and really made this thing work better. And then they're like, oh, Stewart's organised, we'll send him to theatre when there's bone school on a Friday and there's no other registrars around, so I'm operating with a couple of the consultants. And they all thought, oh, this guy's really keen, he must want to do orthopaedics because he's doing all this stuff with the unit. I'm like, no, it's just the unit's a mess and I can't handle mess. And so they encouraged me and they gave me a bit more activity in theatre than probably they would have to other people because I was actually being helpful. And then when I sort of thought about it through intern year, and I really didn't like the medical rotations the next year. I knew I didn't want to be a physician. I was still thinking maybe radiology at that point, but you can't do that as a resident. And then I picked a surge year, and then at the end of intern year, I said to my emergency supervisor, he said, "What do you want to do?" I said, "Oh, maybe surgery, but I don't know." And he said, "If you don't want to be a surgeon, 120%, they'll eat you alive." And I'm like, "Well, screw you. No, that's not the case. Maybe I really want to do it." And then I got given ortho first up again as a second year. I thought, this is a bit strange. Then I turned up to the first meeting, and one of the heads of the unit came over and tapped me on the shoulder and said, "Yeah, good, we asked for you back, because now we want to do this and this and this." So it just sort of happened for me in that way. But I think the key learning point there is, if you're organised and just help the job run well, then you'll be... The consultants know what's going on at that junior level, rather than the person who runs to theatre and tries to demonstrate they've learnt the 16 branches of the carotid artery or something like this, while there's someone stroking on the ward and 20 discharge summaries that haven't been done. Any other questions?
Moving on from that.
Yes.
What's your thoughts on the state of EMR in Victoria and Australia at the moment?
We're really deviating off now. So I was involved in NETA, which is the National E-Health Transition Authority, until it dissolved in 2013. It's pretty abysmal, health IT. There's a lot of stuff that needs to be done. There's a lot of potential, but it's just not happening. The kids is great because it's all on Epic, which is this big... They paid $50 million for this American computer system, which works really well. So the whole hospital is digital. There is no paper. But we've got a long way to go before that gets better. But we might leave it there if we're deviating off a little bit. Thank you for listening to me. If anyone's got any questions, either now or along the way, that they think of later or don't want to ask in this environment, feel free to send me an email or something. I can only speak to the personal experience of someone who is from Melbourne, grew up in Melbourne, went to school in Melbourne, has parents that are from Melbourne, and has gone through in uni in Melbourne. So if you want to know about people who've come from a different experience, or want to find someone who aligns in surgery with your own, we are a lot more diverse than we may appear. So I feel bad about me presenting here. But let me know, and I can put you in touch with someone who'll mentor you along and talk to you about things that I may not be able to give you the best answer for. Okay? Very good. All right. Thank you very much.
Thank you everyone for coming along today. Hopefully it didn't take too much time, and I hope you enjoyed the more personal aspect of Pathways into Surgery. We had a lot of people telling us they wanted more of what people's actual experiences were, rather than just how to get into racks, how to get into surgery. So if you do have any comments or anything, feel free to just let us know. We hope you enjoyed your night, and yeah, enjoy.